Hi, I'm Debbie Hipps. I'm a GP in Lambeth, and I'm the primary care lead for the South East Genomic Medicine Service Alliance. And I'm here today because I want to talk to you and show you how easy it is to request a genetic test from primary care. I'm going to start off with a little bit of basic science because that's going to be important to help you interpret the test and the test result. So you may or may not be aware that each of us carries 3 billion base pairs of genetic information in our genomes, and that each individual has approximately 0.5 to 1% of variance compared to the standard reference genome. And those are responsible for things that make us individuals. They can be anything from a single base pair change to a bigger insertion or deletion, moving bits of DNA across the genome, or replicating and having copy number variants. and they can be in all tissues in our bodies, so having been inherited in our germline, or can be in just some tissues in the somatic tissue. When we get sequence analysis, we identify all these variants, and then there's a complex bioinformatics pathway that helps to analyze those variants and produce a meaningful report, because the vast majority of the variants that we carry are benign. They don't cause significant changes. They might change our eye color or our height, but nothing that would be classified as pathogenic. A very small number of variants are pathogenic, and then there is a probably slightly larger number that of variants that we don't really understand as yet. We call them variants of unknown significance. Now, when we think about genetic tests that GPs might want to do, the one that is most likely is to try to understand if our patient could be a carrier of a cystic fibrosis variant. And this is just a case example I made up. A young woman who's come to see you and her nephew has cystic fibrosis. We know that that's an autosomal recessive condition. Her sister is a carrier, not affected, but that does give her anxiety and wants to know whether she needs to be tested. So we know that she could be a carrier, and therefore her risk of having an affected pregnancy is not the same as it would be for the general population. We don't want to just reassure her. We know that cystic fibrosis is screened in the newborn heel prick test, but we can do better than that. We can determine whether she is a carrier and whether her any future baby might be at risk of cystic fibrosis. Because if she is a carrier, we would then offer to test her partner, and then if they are both carriers, we can offer them pre-implantation genetic testing to select an embryo that doesn't carry 2 copies of the variant that would give a newborn actually cystic fibrosis disease. When we're thinking about genetic tests, these are all listed in something called the National Genomic Test Directory, and the tests are all carried out in very specialized and carefully managed genetic lab hubs. And on the right of this slide, you can see the 4 tests that GPs are allowed to request. So we can do CF carrier status, we can do hereditary hemochromatosis, alpha-1 antitrypsin deficiency, and Gilbert syndrome. And in the National Genomic Test Directory, each test has got a page which details the criteria that the patient would have to meet to be eligible for the test, who can request it, and what test is done. So this is the CF test carrier test page. The test number is R185, and you can search and find these tests in the test directory index, and then go and have a look at the page. So the testing criteria that are relevant really for us is the family history, number 2, the family history of CF in a close relative. So anyone with a family history up to 4th degree, so a cousin's child or closer, would be eligible for CF carrier testing. equally a partner of a known CF carrier, which should be tested. There are some other criteria that they might meet, but much less likely in general practice. In the requesting specialties, you'll see at the bottom we are listed as able to test, and the bottom section of this page shows you the test that is done, which is actually sequencing of the CFTR gene. So a targeted test. We're not doing whole genome sequencing, we're just looking at the CFTR gene. The box on the right gives you a link to a test request form, which I'll talk you through in a little bit. But before I jump onto that, these are the pages for the other tests that GPs can do, in case you are interested. So hereditary hemochromatosis, I think some people will do. So for patients with unexplained iron overload, equally those tests can be done in haematology, and patients, you may prefer to refer them to haematology for that testing. Alpha-1 antitrypsin deficiency, the testing criteria are a little bit complicated with enzyme levels that are difficult to interpret. And Gilbert syndrome is a new test that's been added to be requestable by general practice, but the testing criteria say that only to be done when molecular diagnosis will contribute to management. And I personally can't think of any reason why it might contribute to management, so I don't think we're going to be doing that test. How to refer for genetic testing. So you check your patient does meet the eligibility criteria. And as with any test, you include as much clinical information as possible to help the lab to do the test and analyze it. There's a test request form, which is on the GMSA website. And there's also something called a record of discussion form. You collect a simple EDTA sample, and that goes from to your local lab, where it will be sent on to the genomic lab. You might want to consider whether the test needs to be urgent or routine. So this lady is being well organised. She's come prenatally, and so it can just be a routine test. However, if she were already pregnant and worrying about cystic fibrosis, then we would want to get urgent testing, and we would do both mum and partner simultaneously so that we get a chance of getting the results back before we might need to do CVS testing to look at the fetal status. So CVS testing would only be done if both mum and partner are carriers. The midwife teams are also allowed to request testing and can manage this, but it may present to you. So the next slide is looking at the actual test request form. So I'm just going to talk you through each section. The left top is the patient demographics. It is important to give ethnicity because that does help with variant interpretation. Different ethnic groups are more likely or less likely to have different particular variants. I already mentioned the EDTA sample and the clinical information in the bottom left box. You need to specify the family history that makes them eligible, if at all possible. If the child with cystic fibrosis will have had genetic analysis, and if that information can be added to this request, it will allow them to target and look even more closely for the particular variant that runs in the family in your patient. We discussed urgent routine in the top on the right-hand side, the test directory number for cystic fibrosis, that's the R185, and then in the bottom section, your details, because you are the requesting clinician and you are going to give the report back to the patient. This is the second page of the test request form. It's not really relevant for the test that primary care can request. It's asking about phenotype in the patient, and our patients don't have any phenotype there. All of these symptoms are and signs are absent because they are potentially just a carrier. The test, the record of discussion form I've got here. Doing a genetic test is a little bit different than doing a full blood count because there are some slight complications that are important for the patient to understand before they go ahead and do the test. So number one is that there may be implications for other family members. So if this lady does have a positive variant identification, there may need to be some cascade testing offered to other members of the family. There may be some uncertainty in results. So although this is less likely in the primary care tests, for example, in the cystic fibrosis testing, the 50 most common variants are looked for, but there can be some very rare variants that might not be noted. So if you get a negative result, you are saying that there's 90% certainty that you do not carry the cystic fibrosis gene, but there is a small chance you have a rare variant. That's why if you know the variant that is running in the family, it's a particularly useful piece of information in case it's one of those rare variants, then they can specifically look for it. Section 3 on this form is not relevant to GP testing. We are only doing targeted testing. We are not going to get unexpected information like this patient is a carrier of a BRCA gene or a Huntington's gene. We're not doing whole genome sequencing. The DNA will be stored, the sequence will be stored, the data will be stored, and we would hope that this will go into their test, into their health record, the result of the test. I just mentioned this, the standard CF carrier test looks at the 50 most common variants. So a normal result is reassuring, but there could be a rare variant. And please let the lab know about the variant in the family. If the result is positive, the patient's partner would need testing. If both are carriers, there's a 1 in 4 chance of an affected child, and they can therefore go to clinical genetics to discuss reproductive options. So this is an example of a dummy report. Homer Simpson is not a real patient. At the top of the report, there is the patient's details. The next section down is why he was tested. So he had a family history of cystic fibrosis, and his partner is pregnant, and they want to know whether there needs any further screening. The result summary in this case, they have found a variant, and he is a carrier of cystic fibrosis. And down at the bottom are the technical details, so what exactly they found in the analysis. You don't really need to worry about that technical detail. You do need to think about the implications of the result. So the partner was also tested at the same time. So there's a second report for Marge, who fortunately is not a carrier of any cystic fibrosis variants. And so the risk of the child being affected is down at 1 in 195. So the report will talk you through the implications and the recommended actions. So in this example, you might want to offer other members of the family cascade testing to find out if they're carriers so that they can have pre-planned reproductive options. But in the case of the current pregnancy for Marge, there isn't any need to do any further action. So if you need to look for some other support, there's a website called GE Notes that's got a page about cystic fibrosis carrier testing. And there's also more information on the Southeast GMSA website, which you can go and find. Both the test form and the record of discussion form are also on that website. There are also, if you need any further support, the clinical genetics teams at St George's and at Guy's and Thomas's can give you further support if you email them, or as can I. So hopefully that's helped you to understand how relatively simple it is to request a test and what to do with the result. Please look at the websites that I showed you previously if you want to find the forms or get any further help. Thank you.